Good morning, everybody, again. I'll start by a small introduction, and then I'll give you the floor, Zeenat. So first, I'll talk a bit about me, the Climate Action Accelerator, the Future of Hospitals and Health System initiative, and what is the format of these future talks, Hospital Future Talks. It's number 2 today, and the theme is Rising the Bar for Quality of Care with Dr. Zeenat Sulaiman Khan. And I won't introduce you, I will let you introduce yourself after me. So a bit of background. My name is Alexandre Robert. I'm a health program manager at the Climate Action Accelerator and a nurse by background. With also some expertise and experience in public health or planetary health. The Climate Action Accelerator is an NGO based in Geneva. Our mission is to deliver climate resilient and low carbon actions in different sectors and also in the health sector. We implement projects, we organize some capacity development, and some things we do as well is try to amplify this change. And that's why we commit in the Future of Hospitals and Health System initiative. The secretariat of this initiative was run by the Geneva Sustainability Center of the International Hospital Federation until last year. And we took over the secretariat this year. And in the initiative, we will try to have a rolling secretariat with the different members. So, the Future of Hospitals and Health Systems initiative, its mission is to support hospitals in vulnerable settings and low-resource settings to respond to the growing demand of healthcare in a sustainable, resilient, and equitable way. Today, we will speak more about the quality of care aspect of that work. Our audience is mainly healthcare hospital leaders, different experts of health systems and hospitals, also financiers such as public development banks. We had quite a lot of webinars on the topic. And on the emergence of this initiative, in late 2023, a consortium of 5 organizations with your organization, the Aga Khan Development Network, Zeenat, along with the Chaîne de l'Espoir, the French Development Agency, and the Geneva Sustainability Center I mentioned earlier, and also the Climate Action Accelerator, we launched that collaborative initiative. Our vision is to support hospitals in low resource and vulnerable settings to adapt their infrastructure, processes, and service delivery. As I said, in the context of growing demand, crisis in this work, shortage of staff, etc. Our specific objectives is we would like to exchange good practices. We would like to develop future hospitals models and also contribute to a transformation agenda of the hospital sector and its health system at both operational and policy levels. So over the last 2 years, we were more focused on organizing webinars, sharing experiences between, I would say, more hospital leaders, public development banks, and experts. We saw a good demand for this kind of formats and, I would say, knowledge exchange. And this year, we want to move more from events, webinars, or talks like today to organizing some operational supports to some leaders. So at the moment, it's just a bit of a teaser. The platform is organizing itself to be able more to deliver this kind of community of action, community of practice work. And maybe that would be good to hear your perspective on that, Zeenat. To finish on the future talks, we thought that we had quite a lot of webinar formats with limited time for experts and inspiring speakers to talk. And we thought for profiles like Sonia Roshnik, who launched the initiative for the Geneva Sustainability Center, or you, Zeenat, or the coming speakers, it was good to have a format where you have 40, 50 minutes to really share your vision, your wishes for the systems and hospitals, etc. So this format is made for that. I'm going to start by an overarching question after you introduce yourself. I have some prompts ready, but you're free to speak for 20 or 30 minutes without me interrupting. That's the first block of the talk today. Then after, in about 20 minutes, I'll turn to the audience and ask you to post your questions in the Q&A tab or in the chat of the meeting. You can do it as Zeenat speaks, and halfway of the hour, we'll look at it and I'll ask the questions, take the questions and ask them to Zeenat. And I see some people are introducing themselves in the chat. Please do. We're a growing community of people interested in this topic. So please share who you are, try to connect, and please feel free to connect to us so we can answer your questions. Okay, I've talked enough in terms of introduction. So Zeenat, can you say a word about who you are and your perspective on the topic today?
Absolutely, with pleasure. Let me start by thanking you and FHHS leadership for firstly initiating this amazing talks, and let's not call webinar. So, and secondly, for inviting me to be one of your first speakers as well. So, hello everyone. Some of you might know me, but a quick introduction. I am Zeenat Sulaiman Khan. I'm based out of East Africa. Home is Kenya, Tanzania, and Uganda. Whichever country you feel closer to, you can make me a resident of that country. I'm happy with all three equally. I am a nurse by my initial training, a very much hands-on operating room critical care nurse. And after my nursing, I went into quality patient safety journey, became the quality sort of manager in my institution, and from there moved to become chief nursing officer along with the quality officer. Today, I am working as the regional CEO of Aga Khan Health Services East Africa, which I just talked about. But more importantly, within my agency, which is Aga Khan Development Network Health System, I am also leading the global quality initiatives of our agency. So it is an absolute honor and pleasure for me to be part of this amazing organization, Aga Khan Development Network and Aga Khan Health Services and Aga Khan University. Just to recap who we are, because I am what my organization is. Aga Khan Development Network institutions, Aga Khan University and Aga Khan Health System, we work in 8 countries. And these 8 countries, when we talk about 8 countries, I'm talking about all of them in East Africa, Pakistan, Tajikistan, Syria. So we are in a lot of all our countries, Afghanistan, all our countries are which with limited resources and challenges which I'll be talking about as we go along. We have in total about, and I'm sorry, I'm gonna go back to my notes and talk to you guys on that. But we have we've looked at 14 million, give and take 14 million patients around the geographies we work in. We have about 950 AKDN owned, operated facilities. So you can imagine, and about 4 million communities are involved with us for various other projects related to community programs. So it's a strong network of international healthcare provider. When we talk of health quality, when we talk of quality in AKDN, we really use the IOM, Institute of Medicine definition of quality, where we talk about STEEP, STEEEP, safe care, timely care, effective care, efficient care, equitable, access of care, especially considering the parts of the world we, AKDN, are present. And P, last but not the least, is patient-centered care. So that is what our mantra is. And as we go along, I'll talk more about it. But as AKDN institutions, regardless of where we are, we talk, think, steep. And all our clinical initiatives of quality and patient safety revolve around STEEP. So that is who I am and the organization which I am honored to work with and lead the quality agenda. Okay?
Very good. Thank you, Zeenat. Can you repeat the P of STEEP because it cut on my computer? Maybe it has cut for others as well.
So P is patient-centered care.
Patient-centered. Okay. Thank you very much. So I'll now give a quick recap on the first session. As you know, Sonia Rochnik, with whom you initiated the Future of Hospitals and Health Systems, because for our audience, I think critical people to start this initiative were Zeenat and Sonia. She always mentioned this anecdote of you organizing a breakfast at the World Hospital Congress on sustainability, expecting 15 people with 15 croissants. That's my takeaway of the story, and having 3 to 4 times more people. So the first problem is not having enough croissant, but a good opportunity is that you realize that there were a growing demand and expectations on that topic, and that made the emergence of the future of hospitals and health systems, which has now sessions in every World Hospital Congress. So Sonia said a bit about that, and as you know, she shared her perspective of what is green universal healthcare, the need for resilience that is good for quality of care, the role of healthcare professionals, all the topics you know are close to her heart. And based on her very long experience on sustainability and healthcare since the NHS about 20, 30 years ago to now being the exiting director of the Geneva Sustainability Center. So that was overall about the vision of the initiative. And now we will focus on what is maybe not put forward sometimes when we talk about climate change, sustainability, resilience, or other crises, but what is central, anything we do around it should be for quality of care. So you've told us about how it matters for AKDN, AKHS, and AKU. A little comment on this is that I'm always impressed by the number of people you deliver care to, like 14 million. It's more than Switzerland, where I sit now. So it's like a middle-sized Ministry of Health. So based on what you said on the STEEP, maybe you can come back to the STEEP. Why is this framework critical also for, in terms, you've said equity, but also in terms of resilience to climate, but other aspects, and overall sustainability, reduction of pollution, reduction of emissions. So how do you link the two?
Great question. When we look at our statistics on, no, let me take a step back. When we started talking about FHHS, what is healthcare all about? Healthcare is all about people, the communities we work in, promotion, prevention, cure, rehabilitation, palliative, and death and dying with dignity, right? So starting from birth to death is what health is all about. Health is about people. Now, when we talk of health and people from birth to death, the whole spectrum is we want to give to our patients, our consumers, our community, and our clients STEEP. That's the STEEP. We want to give them safe care, timely care, where it is needed care, efficient. The efficiency or in a hospital can be measured differently, but in community it can be measured differently. So when as AKDN leadership, we talk about the spectrum of our presence from community birth, where our community health workers, our midwives are delivering, to all the way into fancy buildings where we have cancer care and radiation oncology. How do we fill the steep in the full spectrum? And believe you me, every step of this journey of a human body and the communities, the steep very comfortably engages in. So when we were looking at our own framework, we realized that yes, steep is a framework which is not focused on one part, but it can take us through the full journey. Let's talk about uh, resilience. Let's talk about sustainability in healthcare, in quality. When we were doing FHHS, we were looking at themes. What should be our themes? Of course, it's so important now. Environment and health needs to be merged. Very important. Health financials is so important. That's where you alluded to earlier, that we have other health finances partners. Human resources is so important. So quality of care is really the outcome, guys. The outcome of a lot of processes is what I get as an individual patient or as a community is the quality. It's really the outcome which we are giving by putting all our heads together in structures and processes. And that's where, with IHF, with AKDN, with AFD, Geneva Sustainability Center, we said that it is so important that one theme should focus on this quality of care outcome. When we look at, WHO has told us that about 5.7 to 8 point estimates 8.4 million deaths each year are attributed to poor quality of care in low and middle income countries. And I'm telling you, one thing which we have been talking about more and more, no healthcare cannot be substituted by poor healthcare, right? And that is where the problems are starting to come up, that we have issues in lower and middle income countries where absence of care is being substituted by poor care. And that's where quality of care is so important, to be part of the planning of provision of care to the communities and through the hospitals and so on and so forth. Poor quality care has represented up to 15% of overall deaths. 15% of deaths, guys. So we talk about deaths related, when you do M&Ms, we do deaths related to patients' intrinsic factors, etc. But then 15% of that is because of poor processes in a hospital or poor assessment by a practitioner in the community, and so on and so forth. So really, quality as an outcome cannot be there if we do not start thinking about it from the inception of a program going all the way to the outcome. When we talk about sustainability and quality, how are we linking it? And that's your question, how is quality care is linked to sustainability? Think about it, guys. Clinically, how the sustainability, clinical outcome sustainability is so linked, because we cannot just work on CLAPSIs or hospital acquired infections. What are they? If you look at C-section rates in our public hospitals, in our private hospitals, what are those C-section rates? How are we dealing with surgical infections? How are they leading to mortality, morbidity, and mortality, maternal morbidity and maternal morbidity, or neonatal morbidities and mortalities? They're all linked together. Financial, because preventing harm and complications reduces cost. Sustainability. Our finance team, I know I'm a regional CEO. We are always counting pennies and pounds because it matters. But how does good quality, safe quality is leading to cost of poor quality? Cost of poor quality means dollars and euros for us. Socially, communities are more likely to trust Aga Khan name for its human resources, for controls over quality processes. For we go for certification, and I'll talk about accreditation and certifications later as well. We go for certification of safe care. We started with ISO when 30, 40 years back, we did not have hospital healthcare related certification, but we said we want to go for international standards. We started with ISO. We are at Safe Care. We are doing JCIA. We are doing SANAS for lab. We are doing HACCP for kitchen, and on and on and on. Why? Because we need to make sure that while we are in Kisumu or Kakamega or in Gilgit-Baltistan of Pakistan or Badakhshan of Afghanistan, we are following international standards, and that socially is acceptable at the international level, and trust is built for us. Last but not the least, in literally environmental sustainability, it is so important for us because efficient care can reduce unnecessary investigation, unnecessary re-sterilization, medications, referrals, repeat visits, going telehealth, going solar, looking at maternal outcomes and babies' outcomes related to change in environment. Health and environment are linked together from at the hip. So it's so important that we understand that quality of care is very, very closely linked with sustainability of a program and also sustainability and resilience of the environmental mother earth agenda, which we all have on our table. So resilience is not only about infrastructure, it's about processes and outcome as well. It's about system and governance. And quality creates the discipline which is needed for healthcare system, hospital to respond to that in a very structured manner. So that's my understanding, and that's our framework which we use to bring sustainability, resilience within AKDN under the umbrella of quality.
Thank you very much, Zeenat. I have a couple of reactions to what you say. So I propose we do in the next 3 minutes a bit shorter answers and back and forth. First small question, you said that, so you talked about attributable death to poor healthcare, that it shouldn't be replacing absence of healthcare. Can you give us 1 or 2 examples of situations where absence of healthcare is replaced by poor healthcare, please?
And guys, we participants who are from LMICs, we see that, okay? And I'll give you example of that. When we are looking at cancer care, okay? Cancer care is a spectrum, a true spectrum from prevention, promotion, all the way to dignity of death. That's what cancer care is. Now, when we are looking at a national cancer program, right? A lot of us jump and look at radiation oncology, sexy equipment, and which is good. It will take care of people who need the cure part of it. But that is not the full spectrum. We need first to do diagnosis. We need to go to the community for diagnosis, because if diagnoses are not happening, majority of our patients are coming at 4th degrees breast cancers, and terminal cervical cancers. The outcome is not there what it should be if we look at the total spectrum of the cancer care as a program. So what we are doing is we are picking the pieces which is incomplete and not a complete spectrum of there. Within this, let's look at maternal. When we are looking at maternal, how important it is for us to look at availability of appropriate instruments and medications to our midwives. We are putting the process and procedure, but not giving them the tools to do that. And if you don't give the tools, the outcome is not going to happen. So it is so important that when we are looking at healthcare, we look at it into totality as a disease or a service and ensure that we give appropriate tools and monitor them.
Yeah, okay. So what I take away from this is like this systemic perspective and looking at all the entire patient pathway, as you said at the beginning, from prevention, promotion, care, palliative, and trying to bring all the bricks that makes the healthcare with a good delivery. Okay, thank you very much. I have another question because, of course, we focused a lot on quality of care. So we focus a lot on curative care. How do you articulate at Aga Khan the role of prevention and promotion concretely in your operations?
Um, I'm a firm believer, and that's why I will talk about governments as well. I'm a firm believer of governance. The vision of our institution is driven by the governance. His Highness the Aga Khan himself is being the chancellor, being our head of AKDN agencies, is bringing these expectations to us. He has an expert group of people who are he's not in healthcare, he is not a healthcare professional, but he has people around him as governance who have ran healthcare systems for ever and ever and who is guiding the board. And then they are guiding us at leadership. So the same analogy is in a government. Presidents and Minister of Health and the Ministry of Health. If the governance is strong to give us the guidance on how to move, where to move, we as institutions will figure out and deliver. So for me, AKDN success is the governance. Governance leading to leadership. Yes, in the leadership, we need to have right people in the right place. A lot of time, and no, I'm not picking anything, but I see so many public hospitals, so many private hospitals, physicians are put to become the CEO, which is great. They're physicians, they know how to do the physician work. What kind of training do we have for these physicians to become good, smart CEOs to lead the institutions? For sustainability, and I talked about sustainability of quality, sustainability of environment, sustainability of so many things. So leadership is the second arm of for us. Who are our leaders? Who are our senior leadership and then middle managers? I am convinced that middle managers are the backbone of any organization. For me to get any quality initiatives done in these 8 countries and almost 950 institutions or units, it can't happen by one CEO. It happens by good structure put in place with appropriate middle managers who are trained, their training, investment in their training, investment in their buy in. If they're not bought in, it's not going to go down. So, really, for AKDN, we have taken quality at a very, very structured way. It's not a knee jerk reaction. Remember, our business is patience. What is healthcare? It's patience. What is patience? Steep. So, healthcare is not talking about community and patients. Who will talk about it? And that, I think, has been the success of AKDN for the last 100 years. We have been present in the countries I mentioned to you, and some of them. In fact, in Dar es Salaam, our 100-year will be in 2029. So, and we have improved slowly but surely by making it structured, investing in human beings, getting the buy-ins, and giving them the right tools to go down.
Thank you very much. I was looking at the Q&A tab and couldn't see my mic anymore. Sorry. Yes, I think your way to answer about prevention and promotion is having top and mid manager trained on health promotion, prevention, and the full spectrum of quality of care so you can deliver it with patients and communities. Thank you very much. I see the time running, so after that last question, I'll take some questions of the audience while articulating with other things we can explore more. But one that keeps on coming back with both experts and people that are new to the articulation of let's say health, resilience, sustainability, reduction of pollution. Something we hear sometimes is that that's actually not possible to improve access, quality, resilience, and sustainability at once. That there are trade-offs, that there are things you can compromise, that it is impossible to do it without spending more. So what's your take on these assertions based on your experience?
This is like you were a fly in the wall when we were talking about our budgets just the other day, because that's exactly what we talk about, right? Look, I'm a firm believer that sustainability and resilience should not be an added thing. For me, patient care is my day-to-day job, right? Quality of care is my day-to-day job. So why should, when we talk about healthcare with resilience, carbon emission, why should carbon emission be an external thing given to me to work on? Sure, when we started, it was we needed some push. We did that. But today, as a manager, it is part and parcel of my job. So when we were looking at budgets, we can buy air conditioning we are in Dar es Salaam, which is hot, humid, so we have ACs around us. When we are budgeting for ACs, we question ourselves, which gas are we taking? Is it R32? And if not, why not? So it becomes a normal thing. It's like when I am buying a medical equipment, I ask for the safety of that medical equipment for the patient and for the staff. Why would I not ask the same question now for climate? We just put an MRI, and our first question was halogen gas. Now, there are MRIs without it. So should we not go for it? Yes, we should. And there is ROI attached to it. As a CEO and my CFO, we are all listening to not just that it's good for the climate and carbon emission, but it's also good for us in long-term operations. We were sitting, and my amazing people, AKDN, we are so lucky to have individuals who are expert in guiding us at the healthcare level. We are just in a forum talking about use of gloves or misuse of gloves. Now, that misuse of gloves, the whole COVID and infection control, so we are sitting together to see, do we really need to use these disposable gloves when we are doing this activity in nurses and doctors? Or we can say, guys, we don't need to do it at this time. It's cost, it's carbon emission, it is good for everyone. So I think as the healthcare is maturing, it is a process. Everything, we can't do overnight things. Go green, carbon emission discussions have started in the last few years in healthcare. They were not there for, as longer as many other industries. Anyways, for healthcare industry, it is a relatively newer subject. But for AKDN, we are not separating it as an added agenda. It is part of our mission. We want to go as carbon neutral in 2030 or so. It is my expectation. My leadership, my governance has given it to me. I don't have an option. As a leader, I have to learn more about it. That's why you guys come into play. You guys are amazing to teach me and my colleagues how and what I can do. You are doing piloting in South Africa and Zambia, so I can learn for East Africa, and we work together. So that's another thing. Let's not reinvent the wheel, and don't be scared. I have opened my doors to learning from experts like you, from Miriam and Rolas of AKDN Health System and Fauzia's, who are experts. They have sort of passed that on to us. And now, as healthcare administrators, we will work. Will money be required? Yes, but where is money not required? Money is required, guys. Financial is required for everything. You want to build a clinic, you need money. Equipment, you need money. HR, you need money. But that can't be the excuse. That is not an excuse not to move forward, not to have an objective and a goal in front of you. So, healthcare and climate resilience go hand in hand. It needs to become part of my day to day job and my expectation to deliver, and for me to come to experts who know it so much better than I do to guide me. Hope I answered your question.
I think very good. When I was listening to you, I wrote on my little notebook, safety of the planet, safety of the patient, same fight. That's a bit your conclusion.
Well,
So
great
very good. One of my takeaways underlying what you said is also what I see you doing in your work is identifying big co-benefits. Where can we have better clinical outcomes, organizational outcomes, resilience outcomes, sustainability outcomes, while we reduce costs. So, and we see that in a lot of champions and pioneers doing that a lot, focusing on where there are no trade-offs. Maybe there are trade-offs, but there are so many things to do before that don't imply any compromises and trade-offs that we should all do them. The misuse of glove is a good example. Another one we hear a lot is the smarter medicine, where you reduce unnecessary prescription, you reduce unnecessary emissions, and you save time and you save money, etc. So there are a lot of great examples. I like what you said about using learnings from others, but to be able to use learning from others, others have to share their learning. So please, a message to the audience, anything you do, you document as good results. It's not enough to implement. Please document and share so others can learn and accelerate the action. That's what we're preaching from at the Climate Action Accelerator, to accelerate action. Good. I see we touched on a lot of things. I think so. I will try to take some questions from the audience. So I just need a little time to have a look at it. That's an introduction. Okay. So I'm being said that it was put at the bottom of my document. That's great. Yeah, maybe you can start by this one. It's do you know of a quality assessment checklist to assess hospitals against TIP domains? And can you tell us about this?
Right, sure. Great question. Look, guys, this question tells me somebody's thinking to evaluate a department or a system in a structured way. So, and that brings me to my initial discussion about frameworks. So, look, SafeCare, JCIA, they are accreditation bodies which gives you a certification. But they start with a framework. They start with their standards. They start with their intent. And you can convert them into a checklist, which we did. So today, in fact, JCIA has also started a wonderful journey of quality for LMICs. Dr. Dogra is championing it, and it's amazing. So what are they? If you are in cath lab, let's say you are starting a cath lab, what should be your checklist to see the patient safety aspects, staff safety aspects, evidence-based practice? Another thing which I'm sorry I should have talked about earlier, we are scientists. Healthcare is a science, guys. So for us to be in science, evidence-based practice needs to come. So coming back to the checklist part, if you are opening a cath lab, or if you want to check your own cath lab for the safety of your patient, staff, and evidence-based, these checklists are very, very, very much so available through the good standards. So if you open the standards of so many, in South Africa has COSESCA, beautiful standards. I've talked about Safe Care. I've talked about JCIA. I have talked about JCIA, other framework of quality for LMICs. There are checklists. I mean, they might not be a checklist as checklist, which WHO, by the way, you should look at WHO quality checklist, and you will find CDC has them. So yes, depending on which, if you want to do across the board, do you want to do departments, or do you want to do a service, oncology as a service or radiation oncology as a department? There are a lot of guidance on what to see and what could be converted that into a checklist. So yes, it's available. Happy to work with you guys, whoever asked, if you would like to for us to work with you at that. And really, we as FHHS, please come and talk to me. We will talk about the future of FHHS and moving forward, and one of them is, how do we work together to bring about your and our strengths, and work towards, I always say, don't reinvent the wheel. Go and check out what is available, and that's what FHHS is all about.
Okay. Thank you very much. I'll take another question. So someone explained that health systems, they are distributed a bit unequally, different dimensions, different type, different geographies, unequal and different access to resources, staff, models of operations, etc. So given that context, what do you think are core principles which you think can realistically be implemented to achieve sustainability, no matter the differences?
You know, I am from a not-for-profit institution, and I am a firm believer, guys, that healthcare system cannot be left on one industry. So what are those industries, or who are the owners? Number one, public government. Okay, government needs to take the accountability, but governments can't do it alone. We have not-for-profit or private healthcare sectors, so that's second partnership. But again, when you put us together, we can't do it again. We need a third partner, and those are financiers. So we have our IFCs, our World Banks, our AFDs, our German banks, etc. So we need to have a tripod approach. We need government to be clear on its priorities, its problems. Every country has its own problems, its own priorities. With that, they can't do it alone at public sector. It is our ownership as private and not for private institutions to join with the public. And then we have a third arm of financiers. So the countries I work in, we are just, and I'll give you an example if you allow me, we are just working on an East Africa comprehensive care cancer project. That project is done by Gates Foundation, AFD, and Aga Khan Foundation for giving us the monies. Okay, but we are not doing it on our own. We have government of Zanzibar, Ministry of Health of Zanzibar, Ministry of Health of Tanzania, and Ministry of Health of Kenya. And then we are going into the counties and the regions to deliver the prevention, promotion, capacity building, health, and then equipment, and so on and so forth, and outcome monitoring. So really, for me, there is no simple answer to it. It is a complicated system. However, we have to come together as multi-partners under one roof to talk about how to resolve these problems by services, by population, maternal and child, cancer, cardiac, NCDs, or so and so forth. So I think that's what my take on this question is.
I think my takeaway on this is, like you've shared, there is a need for accountability of the public and governance. They need participation of private non-for-profits that exist. the right finance in place and some structuring comprehensive programs, as the example in East Africa gives. Very good. Thank you very much. Alors, yeah, something we haven't discussed, and it's a good transition. So I'll try to summarize. As you've explained, most sustainable healthcare system is the one in which people is in good health. And more than hospitals, primary care, I would argue even community health, prevention, promotion that you repeat a lot are even more important in that regard. But the private sector, it does not enough participate in primary care networks. So how would you imagine private models to be duplicated more in primary care models more widely? Is that
Look,
clear?
yes, very clear. Look, prevention is cheaper to do, but it's not sexier for the private arm, because it doesn't give you, the yield is not there. Private healthcare is shareholder based. They have to go back to their shareholders, correct? But believe you me, there are systems, and I will give you a system in the United States, which is called Kaiser Permanente. Kaiser Permanente is a private system which is working on how to keep patients out of the hospital, right? And that is the reimbursement model. Now, that's the principle for the public sector, but that's and I am a big fan of that system. It's not widely being utilized. I am very proud to say that in AKDN, we are doing it. Okay, in AKDN, what Kaiser Permanente has done is that the financing of health system is also under their domain. So they are saying, let us spend less money into the communities. Communities don't come to the hospital and spend more monies, and that's where they will give their insurance money to the hospitals. So their leaders are paid to keep patients out from the hospital. Majority of the private hospitals are always looking for patients to come into the hospital so they can make money. So that's the mindset change, guys. That's the mindset change. And I think the governments play a very important role in guiding the private and not for profit on what their expectation is, right? So again, I go back to the same thing. Let us work together with the governance. It is complicated. It's not as easy as I made it. Prevention is cheaper, but prevention also does not give enough yield to the shareholders. So how do you balance that? Who is your financier? If your financing is also a private insurance, everybody wants to make money. But that doesn't mean that there are no models outside where you can bring. AKDN has been successful. Yes, we struggle. We struggle in getting the funds into the communities, but we have very strong community model of community health workers who are there looking at MNCH, NCDs, bringing the patients not straight away to our regional hospitals, but to we call it hub and spoke model. So our hub is the tertiary care and secondary care, but we have spokes which are cheaper for the community to afford, which is easier and accessible. So we have come up with our own model of hub and spoke to deliver as much as we can. It is not perfect. I don't think any system of healthcare is perfect in this world today, but we all have to work together on it. And governments need to play part, institutional leadership and governance. And I am telling you, I will go back and give kudos to His Highness the Aga Khan, our leaders, their vision to serve the community, which communities where we work.
Thank you very much. I was trying to highlight one part of the last question because time is running. It's 52, so we'll try to finish in 8-10 minutes. We always allow ourselves with for 1 or 2 minutes more at the end. One reflection on what you said, something I see emerging a lot on the positioning of the private sector is on digital health and telemedicine.
Yeah.
Here in Switzerland, there are programs financed by private insurances to private sector healthcare delivery to reach out patients where there are no doctors, to create a buffer in pediatrics emergency to like manage some issues over the phone that don't end up in the emergencies. And there are a lot of evidence shown on this. And that's, I think, one area
Telemedicine.
where, yeah, private sector is expanding in primary care and or supporting primary care in some models. One conclusion on this, I see that sometimes there is a trade-off on relying too much on digital with its own footprint compared to real primary care with real people. That could be a topic of a future talk.
Absolutely.
So in 1 or 2 minutes, can you give us simply how you see the integration of climate change within healthcare services with a reflection on certification processes? Thank you.
So you know what? As I mentioned earlier, we cannot we cannot take it as a separate thing. It's part and parcel of our day-to-day job. If we look at, as I mentioned, Joint Commission, Safe Care, they have added basic steps of how you and I, as healthcare administrators, as doctors and nurses, need to think about Mother Earth. And there are standards which are available outside. We can look. They might not be perfect for to make us. We are not the experts of that. But as healthcare, we need to start thinking about it and looking at it. So while our governments, as I say, inshallah, one day will make these things mandatory to all healthcare institutions and this industry, please look at various standards available today as a framework, as a checklist. Start thinking about, do you even monitor it? If you monitor it, what are your high carbon emission aspects? If you know that, what can you do? Smaller steps. You can't just start by saying I need 5 million, because that's not true. There are small steps. Our housekeepers, our nurses in operating room, our infection control, our surgeons, our pediatrician of giving inhalers to babies. So there are small steps we can start with. So my urge today, we need to start today. We can't wait anymore, guys. Don't. We as healthcare are 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 one of the culprit in this carbon emission, and we need to respond to it today. So look at some of these standards, go for some of the initial steps of how you want to start, prioritize your needs. It cannot be millions on day one, but once you start the journey, it will become part and parcel of your day-to-day job, your annual budgets going forward in the next few years. That's how it has happened with us. We started with small steps, but today AKDN has a measurement tool on website in WHO. It's for free. Take it out, use it, and see how you can. And I said, do not reinvent the wheel, guys. Come back to FHHS. We are here to work with you guys. There are experts who will guide you and me and us to take these steps forward.
Thank you very much, Zeenat. And I would add to this beautiful answer that now there are trainings in different repositories everywhere. So please explore it. If sometimes you don't find your way, you can reach out to the Future of Hospitals and Health System, or you can reach out to the initiators or like the publishers of a training, and they will orient you because maybe that training is not the best fit for purpose, and they know the other one that is more fit for purpose for yourself. And I'm thinking maybe we should have a repository of these repositories on the upcoming Future of Hospitals and Health System
Great
website.
idea.
Yeah, by the way, over the summer we'll have a standalone website of the initiative coming, I hope. It's a bit of a teasing since we are towards the end. So we have 3 minutes before the end. So before I ask you for the final words, a suggestion to integrate in your final words, is a bit the question of the shortage of staff we have globally and in places. I think we didn't address this. So with this in mind, why is rising the bar for quality of care so important and so urgent right now? If you can give a
I
closing
think
remark.
quality of care has always been our bread and butter. I keep reminding myself and my teams, we deal with patients, we deal with people. We are not an automobile manufacturer industry. We are a healthcare people's industry. People don't come to us by choice. They come to us because they need us. How can we not think of quality as our core objective? So for me, quality is not an afterthought. Quality is what we do. We provide care. And let's define care with the definition of quality. It is so important for us, guys, that we don't feel we are alone. We are not alone. We have partners who are going through the same journeys in the same countries, and we have experts who are there to help us out. So let's not feel alone, feel frustrated. Let's tap into and let's not reinvent the wheel. There is enough outside to define quality, to define carbon emissions, to define sustainability. Let us ask for help. When it comes to us working, and I'm now talking of FHHS, when we are talking about FHHS, this forum is is for all of us to work together. We are here to open doors to many of these resources which is present around. So please come to us and work with us, where we would like to partner with you all and with the governments and with impactful results. Impactful results is what I think is important. But quality cannot be an afterthought. It is our business. And now, quality is not just that the patients are dying, but it's about how are you providing quality through access, through evidence-based, through making sure that our practices are not affecting Mother Earth, because we cannot be the ones contributing to that issue which we all know and we all talk about. So as hospital leadership, I think my request is, let's ask for help, let's learn from each other and continue on this journey. It's a journey, it's not a destination. It's never a destination, it's a journey for us.
Thank you very much, Zeenat. I think that was great, and we'll try to document what you just said, and maybe in the upcoming website listing some of the resources you've detailed. So in 1 minute, I'll give a bit of a concluding word on what comes next, and some messages to the audience. So I will repeat that every future talks. What we are trying to do with the future of hospitals and health system is moving from community mobilization, which we do in a format like today, to more operational learning and investment support with some groups of development banks. For that, we have a couple of deliverables around practical guides, how to model the cost of the co-benefits around quality of care, sustainability, resilience, cost, etc., or what could be concretely in a low resource setting, a green and resilient hospital. That's just to give you a few teasings of what we want to work on. What we think we will do over the summer by the end of the year is a bit of a survey of our audience and community to know your expertise, what you want to work on, how you would like to contribute. So that's upcoming. I think that's it for what comes next. One important thing is that by the end of the year, we will have 3 other talks. So potentially one in September and in the coming month. So please stay tuned. We will tell you who's our speaker soon. If you like this format live, if you like the recording, if you like the podcast, please share in your network. That's very important for other people to hear about the work we do here. And if you have ideas or projects that require support or you would like to partner with the initiative, please reach out and we'll be very happy to follow up with you guys. Thank you very much, Dr. Zeenat, today. That was a great talk on the importance of quality of care. As a nurse myself, I found that very great. And we have something more in common that we never discussed is that I also started to work on cardiologic critical care 15 years ago. So we should have a chat about this later.
We shall. Thank you, guys. Thank you for your time and thank you for giving me the opportunity to speak to you all. Bye-bye.
Thank you.
See some of you in Seoul, guys. We are meeting in IHF there. So hope to see you there.
Yeah, Seoul is the World Hospital Congress in November, right? Is it October or November?
No, October. It's October. Please look at IHF website and you will see it is absolutely great presentations and abstracts from around the world, from all around, with all these discussions which we had, finances, HR. Sorry, I didn't talk much on that, but HR, innovations, which is a new buzz coming up, AI. So if you can, come over and listen to some of those exciting things.
Thank you very much. And I also say hi to the name of the friends I see in the chat. Thank you very much. We're going to close the webinar now. And stay with me, Zeenat. We can have a small debrief of 5 minutes.
Absolutely. Thank you, guys.